Right. Okay. Hello, good afternoon, everyone. We will be just when no persons are coming in, so we'll wait another minute and then we will go ahead and start. Good afternoon, everyone. Welcome to this afternoon or NCD Rounds webinar series, Prepared to Care. Right. So this afternoon for session, we will be, just want to say thank you to everyone for coming out to this afternoon session. We really appreciate the time that everyone would have taken out to attend our session titled our NCD Round Series, Prepare to Care, Strengthening Healthcare Worker Capacity for Diabetes and Depression Screening and Continuing Care in Emergencies. So we want to thank today all our guest speakers that would have joined us and to thank you also the participants. So the purpose of today is to share an update in terms of our national guidelines on diabetes and depression, but also we would be looking at enhancing providers with the ability to deliver psychosocial support and also to maintain the continuity of care during emergencies in the post-disaster setting. So at this point in time, I will now go into us going to the national anthem, and we would just go into the national anthem for Jamaica. Right. Thank you, everyone. So At this time, we will now head into our pre-test, and we would please ask for everyone to you can scan the QR code, and we are assigning 5 minutes to do our pre-test, as we would have seen by the flyer that this session would be CMEs. CMEs would have been requested for the session. So please, if you can complete the pre-test, and then we would then head over to the next part of our session for this afternoon. So 5 minutes for CMEs. So both the QR code is up, as well as the link for the pretest has been dropped in the chat. So persons who are just coming in, welcome, good afternoon. The pretest QR code is up, as well as the link is also in the chat. So persons can feel free, 5 minutes for the CMEs. So it's now 8 minutes past 2. And we will then move on in 5 minutes time from now, from doing our CMEs. So quickly, persons can just go on and just do our CMEs, the pre-test. Three more minutes remaining. And at the end of 3 minutes, we would move on past our pre-test. So 3 more minutes. All right. So thank you everyone for participating in our pre-test. And at this time, we will now hand over to Dr. Temu Davidson, who is the director for the NCDs and Interprevention Unit, to bring opening remarks. Dr. Davidson?
Thank you, Dr. Brian. Good afternoon, colleagues and friends. It's certainly an honor to welcome you to today's webinar, which is in commemoration of World Diabetes Day and Month of Awareness, but will kick off as one of our series of activities under Miss Sweet year-long campaign, which we'll launch soon. But this webinar is also a moment for reflection, renewal, and shared purpose. As we observe this year, it comes at a time when Jamaica continues to recover from the impact of Hurricane Melissa. Our nation's resiliency is being tested, has been tested, and so is the strength of our own health system and workforce. Many of you joining today are not only health professionals, but also survivors, caring for others, even as you rebuild your own lives. So I want to begin by acknowledging your courage, dedication, and the compassion you continue to show in the face of adversity. You remind us that healthcare is not just a profession, it is a calling rooted in service and hope. Today, we focus on key issues that have become even more urgent in our reality. As screening, we'll look at screening for diabetes and depression, managing non-communicable diseases in disaster settings, and look at how we can provide psychological support in this emergency setting or disaster setting for patients and also ourselves as providers. These topics are deeply connected. Disasters disrupt care, interrupt medication supply, and strain both physical and mental well-being. Yet they also reveal the critical importance of preparedness, teamwork, and community-based support. As we reflect on Jamaica's recovery, we are reminded that resilience must extend beyond just the infrastructure, but it should also include emotional well-being and continuity of care. We must screen more effectively, intervene earlier, and support each other deliberately, especially in the heavily impacted communities where resources are stretched thin. Let today's discussion equip us to do that, to strengthen the systems we work within, to safeguard our own health, and to ensure that those living with diabetes and other NCDs receive continuous, compassionate care, even in the most difficult circumstances. On this month of diabetes awareness and day tomorrow that will be commemorated, let us recommit to healing not just our bodies, but our communities, building a Jamaica where every healthcare worker, every patient has the support they need to recover, to manage, and to thrive. Thank you for your service, and thank you for just showing up and being here today. And I charge you with sharing information from this webinar with just even one other person. And as they would say, we're stronger together and Jamaica strong. Thank you. And I'll hand over back to our moderator, and I'm looking forward to the deliberations for today's webinar. Thank you.
Thank you so very much, Dr. Davidson. Thank you again for your opening remarks. And at this time, we will now hand over to one of our, so the first of our many presenters. We will hand over to Dr. Karen Phillips. Dr. Karen Phillips is a respected consultant physician with over 18 years in the field of advancing endocrinology, mentoring next generation of doctors. Dr. Phillips has a rich background in stroke rehabilitation with 10 years on hands on experience supporting patient recovery and improving the quality of life. She has been teaching medical students and residents in the Doctorate of Medicine program for over 20 years and has served as examiners for both MBBS and DM examination for yearly. Driven by her passion for patient care and medical education, Dr. Phillip continues to make a lasting impact on Jamaica's healthcare system through her leadership, mentorship, and clinical experience. And at this time, we will hand over our first presenter, Dr. Karen Phillips, who will be presenting on the National Screening Guidelines for Diabetes.
Good afternoon, everyone. As usual, it is my pleasure to be a part of any educational webinar such as this, and in particular, a topic which is very close to my heart, diabetes. So I'm very happy to be sharing this afternoon with the National Screening Guidelines. I'm very proud that we are sharing our own guidelines. Well, what we have set up for our own selves. So I'm going to share a screen. I'm going to ask for it. Okay. Okay, so today we'll just go through in the next 20 minutes or so the status of diabetes mellitus in Jamaica, risk assessment, screening for diabetes mellitus across the life course using our own guidelines, looking at the screening algorithm, looking at health promotion and prevention of diabetes mellitus before concluding. So I always like to start with a little context so that you can just think about this patient in your own minds. You can think, what exactly is going on here? Is this patient diabetic? Is he not? And why would you say he is or is not? So BM is a 48-year-old black male who was seen in his local health center for routine follow-up of his hypertension. So he's hypertensive. He's maintained on an ACE inhibitor, lisinopril 20 milligrams daily, and his home blood pressure monitoring averaged 128 on 80, so not bad. His family history was positive for hypertension, type 2 diabetes, and coronary artery disease. So Mr. BM reported a 20-pound weight gain over the past year, but admits to a sedentary lifestyle. He denied asthmatic symptoms of polyuria, polydipsia, etc. So on presentation, he was noted with an waist circumference of 42 inches elevated, a BMI which again was elevated at 34 kilograms per meter squared, blood pressure of 125 on 80. And his routine investigations, they reveal a total cholesterol of 4.9 millimoles per liter, triglyceride of 3.7 millimoles per liter, HDL of 0.75, and LDL 3.3. His fasting glucose was 7.1 with a repeat of 7.3 millimoles per liter 1 week later. So you can think in your head, is this man diabetic or not? And why would I say so? So does he have diabetes? And when should patients be screened for diabetes? And what tests should we use to screen for diabetes? So at the end of this presentation, we would like you to be able to answer these questions. Right. So diabetes mellitus, as we all know, is a major health issue, not just facing Jamaica, but the entire world. It's almost as if it's a tsunami right now. In the Jamaica Health and Lifestyle Survey, this is from 2017 to 2018, it was estimated that 40% of Jamaicans are currently living with diabetes. 25% have diabetes and do not know their status. And in 2018, diabetes was thought to represent the fourth leading cause of mortality among Jamaicans. So very, very important topic, and that's why we are spending time talking about it. And we do know that diabetes really describes, people think of it just as high blood sugar, but it is really a metabolic disorder of multiple etiology. And we must recognize that in addition to the chronic hyperglycemia, there are also disturbances of fat and protein metabolism. and these result from defects in insulin secretion, insulin action, or both. So it's not just sugar, even though sugar is central to diabetes, but there are also disturbances in fat and protein metabolism. Hyperglycemia, however, is a defining feature, and so the definition of type 2 diabetes is usually based on setting a threshold for one or more by using proposed screening tests. So just looking back at the ADA criteria for diagnosing type 2 diabetes in 2024, they use three criteria: the A1C, which should be greater than or equal to 6.5%. And please note that this test should be performed in a laboratory using a method that is NSGP, so this is the National Glycohemoglobin Standards certified and standardized to the Diabetes Complications and Control Trials assay. Or a fasting plasma glucose of greater than or equal to 7 millimoles per liter. And remember, fasting is defined as no caloric intake for at least 8 hours. Or a 2-hour plasma glucose of greater than or equal to 11.1 millimoles per liter during an oral glucose tolerance test. And this test should be done as described by the WHO using a glucose load containing the equivalent of 75 grams of anhydrous glucose dissolved in water. So this is actually the gold standard test. In a patient with classic symptoms of hyperglycemia, however, or a hyperglycemic crisis, we can also make the diagnosis if the patient has a plasma glucose of greater than or equal to 11.1 millimoles per liter. So remember, classic symptoms of hyperglycemia. So this patient should have preceding polyuria polydipsia, so symptoms of hyperglycemia or osmotic symptoms, because we're well aware that patients in a stressful situation can present with stress-induced hyperglycemia and are not actually diabetic. So looking at screening for diabetes mellitus from all local guidelines, which goes across the life course, looking at adolescents from age 10 to 19 years, adults, young adults, older adults, pregnancy and postpartum, and late adulthood, so age 75 years and older. And the risk groups, and looking at special considerations for screening in these groups, starting with the adolescents. So the children and adolescents without symptoms of type 2 diabetes who are asymptomatic and who have no risk factors are considered average risk groups. Children who are and or adolescents without symptoms of diabetes but with risk factors, and these risk factors should include overweight with a BMI greater than 85th percentile for age and sex, weight for height greater than 85th percentile, weight greater than 120% of ideal for height, plus two or more additional risk factors such as a family history of type 2 diabetes in a first or second degree relative. Signs of insulin resistance, such as acanthosis nigricans or abdominal obesity, or a maternal history of diabetes or gestational diabetes for the child's gestation. So that group would be categorized as high risk groups. Going to adulthood, so we're looking at the adults greater than or equal to 18 years with no risk factors, we should start screening them at age 45 years. So that would represent an average risk group. And for the high risk group, this group should be screened starting at age 30 or older, 30 greater than or equal to 30 years. So these are adults with risk factors such as overweight or obesity, first degree relative with diabetes, history of cardiovascular disease, hypertension, HDL cholesterol, which is less than 0.9, or triglyceride level, which is greater than 2.82. So pretty much the metabolic syndrome criteria, women with polycystic ovarian syndrome, physical inactivity, or other clinical conditions associated with insulin resistance. And we know these could include sleep apnea, fatty liver, hypothyroidism, etc. Moving on to pregnancy. So for the adult female in pregnancy, those who are asymptomatic with a low risk of diabetes would constitute an average risk group, whilst the high risk group would comprise those asymptomatic but with high risk of diabetes. And again, risk factors that we would look at would include obesity, increased maternal age, which is greater than or equal to 35 years, or women with a history of macrosomia or family history of diabetes. For the late adulthood or elderly persons, those greater than or equal to 60 years with no risk factors would constitute average risk group, and the high risk group would be the same as the general adult population. So if we're screening children and adolescents from age 10 to 19 years, with an average risk. So we said, remember, we said that those persons did not have diabetes and had no risk factors for such. Routine screening is not recommended for this group. But for the high risk group, and we spoke about all the risk factors, screening with fasting blood glucose or the oral glucose tolerance test should be done. If negative, patients should be rescreened every 2 years. And if positive, we should be encouraging lifestyle changes with a full medical profile and rescreening in 3 months, at which time treatment should then be started and they should be referred to the specialist pediatrician or endocrinologist. So this basically summarizes that. So if you're saying that if the person, the child or the adolescent is asymptomatic, basically, and if they have risk factors, then we would want to screen. And if positive, we want to encourage the lifestyle changes, full medical profile, and treatment if necessary. If they're negative, we screen in 2 years. For adults aged 40 to 74 years, for the average risk group, remember, screening should start at age 45 years with fasting blood glucose or and the oral glucose tolerance test. And if negative, we screen every 2 years. If either of these are positive, then it should be repeated, and a full medical profile should then be done, and treatment should be started with referral to a specialist when required. For the high risk groups, screening should start at age 30 years with the fasting blood glucose and oral glucose tolerance test. If negative, we rescreen annually for all high-risk adults. If positive, we're going to repeat our screening tests. And if either of these come out positive, then a full medical profile should be done and treatment should be started with referral to the specialist when required. And again, just to summarize this, low risk, no risk factors older than 45 years, you're going to start screening. If positive, then you repeat the screening test. And if this comes back positive again, then you do the full medical profile, and ultimately, if necessary, you treat or refer to the specialist. If negative, you screen every year. That is if there's no risk factor. If they're high risk, again, you're going to screen with the fasting glucose and the oral glucose tolerance test. If positive, you repeat it and then do the full medical profile and consider treatment at that point or refer to the specialist when required. If negative, you're going to rescreen at least annually, right? So in terms of the pregnant female who is average risk, so we would normally start screening at 24 weeks gestation with the O'Sullivan's test. So this would looking at also cardiovascular disease risk assessment. This should also be done. If the O'Sullivan's test is negative at 24 weeks, it should be redone at 28 weeks. If it is positive at 24 weeks, then the patient should be further screened with the gold standard oral glucose tolerance test, which, if that is positive, they should be referred to the specialist high-risk clinic. And if the oral glucose tolerance test is negative, they should be rescreened at 28 weeks with the O'Sullivan's test. For those who are high risk, we definitely start screening at the first antenatal clinic visit with the O'Sullivan's test, and cardiovascular disease risk assessment should also be done as indicated. If the test is positive at that first visit, then the patient should be further screened with the oral glucose tolerance test. If positive, from then, get-go, you refer to the specialist high-risk obstetric clinic for continued management. If the test, however, is negative, the patient should be rescreened at 24 weeks gestation. If positive at that time, then the patient should be further screened with the oral glucose tolerance test. If the oral glucose tolerance test is positive, again, at that point, you'd refer for specialist care. And just to summarize this again, we're talking about our asymptomatic pregnant screen at 24 weeks for those who are average risk. And if that is positive, we look with the Sullivan's test, we will do the oral glucose tolerance test and refer to the specialists. If it is negative, we screen at 28 weeks. And you should also, from the get-go, screen for cardiovascular disease risk and refer if needed for further care. For those who are high risk, at this point, we want to screen them at the first antenatal visit with the O'Sullivan's test. We then, if that is positive, the oral glucose tolerance test should be done. And if positive, referred for specialist care, as said before. If negative, we screen at 24 weeks. And from the get-go, from the first visit, is screen for cardiovascular disease risk and refer for further care as indicated. So I had mentioned that we use three main screening tests, but it's very important to note that for our local setting, we do not really recommend that you use HbA1c for diagnosis. Just for screening, yes. And why is this so? So the HbA1c level greater than or equal to 6.5, as you know, is a diagnostic cutoff. And this is used internationally for diabetes diagnosis, but I'm putting a caveat there. So there's also the pre-diabetic range 5.7 to 6.4%. And we do know that A1C is HbA1c is formed by the glycation of hemoglobin. And so it may be difficult to interpret in patients with medical issues which affect red blood cell survival. And so although it is commonly used as a risk indicator for diabetes and cardiovascular complications, sometimes it misrepresents the glycemic big picture for a number of reasons. It represents an average, so it doesn't really tell us about the highs and the lows. So it just gives us one average, which is not really instructive if we're trying to consider what happens on a daily basis. And two, again, as I said before, the National Glycohemoglobin Standardization Program, which was founded in 1996 to regulate HbA1c measurements to the DCCT standards, we have to understand that when we use the HbA1c, we're considering that our HbA1c test is standardized in relation to this. So this program actually calibrates the A1C measurements by outside labs and manufacturers and measures the A1C through their own standards. And this should be done like on a yearly basis to ensure interlaboratory reproducibility. Now, we're not sure if that is being done exactly like that locally. And so largely owing to this fact, well, in countries where this is done, the A1C was approved as a diagnostic tool by the American Diabetes Association in 2009 as a key measure for diagnosing, screening, and monitoring diabetes. So there are caveats to the A1C there. As we said, it's directly related to red blood cell survival. So any condition that reduces the number of red blood cells will affect the A1C level. So hemolysis, splenomegaly, chronic kidney disease, hemorrhage, blood transfusions, etc., and hemoglobinopathies. There are also causes of elevated A1Cs, which again could include hemoglobinopathies, and any condition that would result in decreased red blood cell turnover, such as iron or B12 deficiency anemia. Age and ethnicity are also important considerations because we do know that as we get older, the A1C tends to go up. And also for ethnicity purposes, Afro-Caribbeans and South Asians, we tend to have higher A1Cs than comparable Caucasians. And so when we use A1C or HbA1c to screen for diabetes in our setting, I always, when I get referrals such as these, I always send them to do the gold standard oral glucose tolerance test. And I would want to say that in the majority of cases, when the A1C is under 7, these patients are not diabetic. So this is just anecdotal, but just to say that it's not really reliable as a diagnostic tool in our population, but it's useful to use as a screen. And just looking at just prevention of type 2 diabetes, yes, we are screening, but we would also want to prevent this. And we do know that there are a number of studies, the Diabetes Prevention Program, Diabetes Prevention Study, the King study, there's the Indian Diabetes Prevention Program as well. All of these studies really looked at lifestyle modification trials and looking at the progression from pre-diabetes to diabetes, and basically showed that intensive lifestyle intervention is superior, even to metformin, even to acarbose, to preventing progression to diabetes. So we can always go back to the basics, looking at our portion control, the healthy plate, where portion control is emphasized. Half of your plate should be really looking beautiful like this, vegetables, fruits, but concerned about the glycemic index of the particular fruit that you may be utilizing. A quarter should be your whole grains or ground provisions, a quarter your lean meat. You want to limit butter, use healthy oils, and limit sugar sweetened beverages and food items. So our plate should really be looking something like this. So picture your plate, this is what we want, and this will also help us. In terms of physical activity, we should be aiming for 150 minutes per week. And there's good news about physical activity because we do know it helps us to lose weight, lower risk for heart disease, reduce need for medication, possibly reduce symptoms of depression and anxiety, and especially what is happening in our country at this point, gaining energy, increasing well-being, improving sleep quality, and increasing strength, mobility, and stamina. So we should keep it fun, choose activities you enjoy activities perhaps with a friend, a partner, and add variety to the daily routine. And then now, just in closing, we can't have a session like this and not remember our dear, you know, people in the West. These are our own people who are suffering every day. Even today, I spoke to somebody who still has no shelter and was so concerned and just really, really anxious. And so, if we're going to screening in a disaster management setting, it is very, very important to understand that in the acute phase of disaster management, the immediate priority is identifying individuals who have diabetes to ensure access to medication. Just recently, a parent reached out to me from the country. Her child didn't have any insulin. They were sending to Kingston to try to get insulin. Another child came from Montego Bay to see me. Her insulin had gone bad because she didn't have any electricity. So these are things that we have to look at. Vulnerable groups would also include pregnant women with diabetes and the elderly and those with complications. We need to look for classic symptoms of diabetes in this kind of setting. And we should hopefully have access to point of care testing, whether in mobile clinics or in the regular hospital settings that are still up and running. Supply prioritization, as I said, just making sure that these patients get what they need in terms of their medications, their insulin, which, as I said, most of it needs to be kept at a particular temperature and quickly goes bad, or even oral medications. And then information gathering, so talking to patients, understanding what their own challenges and needs are at this particular time. And looking at the recovery phase for long-term efforts, hopefully we get to a place where we can resume routine care, where our patients can be seen in the primary healthcare setting and referred as needed, where we can address complications and mental health issue, because I'm sure we're having a talk today about this, and I already see that we're having a big fallout in terms of mental health, not just from persons affected, but from persons who are empathize and persons who are really, absorbing all of this. Some persons feeling guilty about being relatively unaffected when our brothers and sisters are so severely affected. And then, of course, ultimately, we hope we'll get to a place where there's infrastructure restoration. So in closing, screening when done should be performed for all high-risk individuals across the life course. The tests should include fasting plasma glucose and 75 grams of oral glucose tolerance test, and the HbA1c with the caveat I mentioned, and the diagnosis of diabetes is confirmed if both fasting plasma glucose and 75 grams oral glucose tolerance test are above their respective diagnostic thresholds. And also if you have two elevated fasting glucose tests at separate times apart, at an interval, if these persons do not have symptoms of diabetes. So we want to follow up testing based on results. We want to retest at 3 years if fasting plasma glucose value is less than 5.6, which is normal, or follow-up testing every 1 to 2 years when fasting plasma glucose is 5.6 to 6.4, which is in the pre-range. And also, we must remember our lifestyle counseling, smoking cessation, diet, and exercise. And at a time like this, also, relaxation activities, mental health, relief, which is very, very important. So just to summarize again, the case study we spoke about at the beginning, I'm sure you will recognize that this gentleman is indeed diabetic based on his two fasting glucose levels, which were elevated, and he does have risk factors for diabetes. So thank you very much. That's the end of the presentation.
Thank you very much, Dr. Phillips. Excellent presentation as always. And at this time, we will open up the floor for a minute for a couple questions, and then we will then head over to our other presenter. So, questions, comments at this time?
They can't speak that.
Hi, Doc. There's one question in the chat. I can go ahead and read it for you if you like.
Yes, sure. Go ahead, Dr. Kathy.
Anonymous attendee. What do you recommend for persons post a disaster storing insulin when there is no access to refrigeration?
Right. So as I said, I have a pregnant 18-year-old girl who lives in Montego Bay who came to see me at the diabetes clinic at KPH just last week. And she, which basically she said to me, Doc, it's stressful. All of my insulin spoiled, and I had to say to her, what is the situation? I guess it was before, like, well, I don't think she has got back electricity. I know a lot of persons in Montego Bay have, but she had no access to any electrical source to get refrigeration. But I did advise her to get any glue and ice, which she thought was a challenge anyway. But that is one of the options, to get out an igloo and get ice and store it in that igloo and kind of replenish your ice at regular intervals. For her, she didn't even have access to that, so I actually recommended that she stay in Kingston with a relative who had amenities, so that until things settled for her.
Thank you, Dr. Phillips. Dr. Brand, there's one more question in the chat and then a raised hand.
Yes.
The second question is it 2 or 3 years to recheck sugar when not a diabetic?
All right, so when not a diabetic, if you're average risk, so over the age of 45, every 2 years. Or annually based on these local guidelines. Does that answer the question?
Right. She's asking to refer to the local guideline, refer to the guidelines again, please, Dr. Phillips. They typed back in the chat.
All right. So we're just gonna go back so we can. So what individual is this though? Is this a young person? Is this over 45? Is this an average risk adult, or is this a high risk adult? Or is this a pregnant female? Because it varies for all of these persons. So if we're talking about an average risk adult, as we said before, if that person has a low risk factor, so no risk factors for diabetes, then you would want to rescreen, if negative, every 2 years.
Or to include 2 at the.
So I'm saying, is it that she wants a high risk person? So the high risk person, as I said, it would be annually. The high risk adult would be, you start screening at the age of 30 years.
Okay, she said thank you.
Mm.
Yes.
Total patient count is what? We'll get so far.
Anybody else needs any further clarification?
Guys, if there's any further clarifications, you can always type in the chat and Dr. Phillips and we can forward Dr. Phillips or can respond in the chat as well. But we want to say thank you as always, Dr. Phillips, for always taking the time out to attend these presentations and to just share the wealth and knowledge.
Sorry,
Yes.
Dr. Brian?
Oh yes, Dr. Campbell.
Yes. By the way, the chat is disabled, so any questions would have to be typed in the Q&A.
Yes, the
And
Q&A.
just to share our experience here in Trelawney regarding the use of insulin, not just Trelawney, in Western region. So we do have we have a support group chat for children and adolescents living with diabetes. And that question came up in terms of the insulin. And certainly, yes, in this part of the woods, electricity is not yet restored in quite a number of places. What the pharmacists advised is that the insulin could be stored in a cool place. So ice is like gold now. So it can be an igloo with ice, but maybe water, and just try to ensure that it is cool, and we can do so for up to 28 days. After 28 days, it definitely would have to be discarded. So that was the advice that we got from the pharmacists.
I would want to add though that we have to define what is cool, because if we're using the insulin analogs, so if we're using like the pens, so like Glargine or Apidra or Novolog, then those definitely can be kept cool at room temperature for up to a month. But for human insulins, they need to be at a lower temperature. So I am not sure that I will be comfortable with just saying to leave human insulins in a cool environment in our local environment, which is not necessarily cool, because it can go off. So definitely I agree for the insulin analogs that can be done, kept in a cool environment for up to a month. That is one of the benefits of using those drugs. But for the human insulins, so we're talking about the Humulin R and the Lente and the NPH, which are stored in a vial, those really should be refrigerated. They should be kept at a lower temperature.
Great. Well, thank you for that information. All right. Dr. Phillips, if there are any further questions, guys, the question answer is there, so you can post your questions there and they'll be answered. But at this point in time, we would really, really, really want to say a big thank you to Dr. Phillips for taking the time out to join us today and for presenting and for the clarity and just sharing her wealth of knowledge, on a topic which I know she holds dear to her heart, diabetes. So thank you so much again, Dr. Phillips. We really appreciate the presentation.
Thank you. Thank you.
All right. So we now will move on to our second presenter. Our second presenter for today will be presenting on the National Screening Guidelines for Depression. And to do such, we have Dr. Kevin Goldburn, who is a consultant psychiatrist and a public health leader with a strong commitment for promoting mental health and wellness and drug abuse prevention. He's a graduate of the University of the West Indies, Mona, where he holds an MBBS degree and later specialized in psychiatry. He completed a prestigious Hubert Humphrey Fellowship in Drug Abuse and Health Service Management at Virginia Commonwealth University in the United States. Dr. Goldburn is part of Jamaica's pioneering Drug Treatment Court Initiative, which successfully integrated drug abuse treatment with judicial oversight. His professional journey includes serving as regional psychiatrist, and he also has tenure as a consultant psychiatrist at the Bellevue Hospital. So we want to extend a warm welcome to Dr. Kevin Goldburn, who is the director for the Mental Health and Substance Use Unit at the Ministry of Health and Wellness, where he comes to deliver the presentation on the National Screening Guidelines for Depression. Dr. Goldburn, over to you.
Thank you very much for those kind words of introduction, Dr. Brian. And thank you for the organizers of this webinar to ask me to speak on screen for depression, showing that depression is very important, as this is really Diabetes Awareness Month, and to include mental health in it shows that the priority placed on mental health has been an important NCD, not to be overlooked, but to be considered because of its impact on other non-communicable diseases. So thanks again for allowing me to be here. Show first slide. So just for those of us who are new, the screen guidelines was from 2020. You can see my slides, right?
Yes, Dr. Goldburn.
Okay. All right, so the screening guidelines for this webinar round. So what we will look at today is what is depression globally? What does it look like? What is it in Jamaican setting? How we go about doing risk assessment and considering for special population, screening for depression across life stages, and also look at screening algorithms as we look at how to go about screening for depression amongst our clients we see in our clinics. A bit of global perspective. So worldwide, depression is considered to be about prevalence about 5%. And of note, I think that 75% of persons, especially those in low to minimum income countries, may actually have mental illness, but are not able to get treatment for it because of lack of treatment providers. And that's why it's so important to have other healthcare providers be involved in the depression treatment so we can cover more persons and have less persons being untreated. Of note, depressive disorders is the second highest cause of years lived with disability when look at the 2021 global survey. And of importance, depression is closely associated with persons who have physical illness and also cause an increase in suicidality. So what's depression in Jamaica? So in Jamaica, in the 2008 Jamaica Healthy Lifestyle Survey, 20.2% were found to have depression. In 2016, it went down to about 14%. Of note, it's twice as common in females as comparison to men. And that also of note that in person of chronic illnesses, then depression prevalence is between 20 to 30%. So persons with a history of diabetes, hypertension, cancers, asthma, and high cholesterol have an increased risk of having depression. Also, persons who are obese and persons with a history of heart attack have an increased prevalence of depression. Of note, persons who would commit suicide, who would die by suicide, that 2% of female population in 2008 would have had suicidal ideation, and comprises 1.7% of males. And suicide attempts in teenagers, 13 to 15 years old, was 22% in 2020, and went on to 18.2% in 2016. So teenagers are very important to bear in mind that they too can become depressed. So the importance of depression screening is that the risk of suicide with person who are depressed, and risk of suicide is greater among men than female, even though we know that attempted suicide occur mostly in females in comparison to men. When person are depressed, it affects their daily functioning, whether it's at home, at work, at school, and that also person who are depressed may have an associated anxiety symptoms, and importantly, somatic symptoms. So they may complain of physical issues, and if you're not sharp enough, you may miss that it's underlying depression causing these physical symptoms of weakness and tiredness. And that also, when it comes with other physical conditions, it may worsen the prognosis of other conditions, such as depression, such as diabetes.
Oh.
And it has been shown by an investment case
So
that
who
Power
extended the
conducted
date? They extended the
that
date?
if you spend enough money to ensure that persons are trained to diagnose depression and have necessary medication for early treatment, the return of investment of 1.1 million Jamaican dollars to ensure those things are in place for early diagnosis and treatment, then it have a return in 5 years of $3.9 billion. So not only it saves lives and improve person's dignity of life to quality of life, but also it can save us money. This is showing the PQ9, which is used in screening, especially for adults, and it just highlights some of the symptoms that person may have. Lots of interest or pleasure in previously pleasurable activities. The person like to watch movies, like to play games, then lose that interest. Person feeling depressed or sad, and notice it's for at least 2 weeks, so not just a one day thing. Sometimes person feel 1 day or 2 days, they may not feel up to it, may feel like a bit down and so on, but it's about a persistent feeling of these for 2 weeks. And also with trouble falling asleep or staying asleep, issues with energy levels, affecting your appetite, may either decrease or increase appetite. Person have low assessment of themselves, difficulty concentrating, even doing simple things like reading. People may sometimes either move slowly or move in a restless way. And then, of course, person may have thoughts of hurting themselves or preferring to be dead than to be alive. And these are all signs which, as I will say later on, will be when you have enough of these symptoms, you may make diagnosis of depression. It's important to know that when we're making diagnosis of depression, we should rule out other things like medical illnesses, substance use, and bereavement, which can have some of these symptoms and which may be temporary symptoms and not necessarily depression. So we're looking at screening for depression across life stages, from adolescent going to elderly, and including persons who are pregnant or in the postpartum period. So let's do the risk assessment first. For the adolescent, you talk about the average risk of persons who are average risk are those who have no history of any chronic illness or mental disorder, who are performing well academically, interacting social with their peers, and have good family support, especially if they have both parents in their home setting. And the high-risk adolescents are those who are in a single-parent home, issue of chronic illness or mental disorder, who may have experienced significant traumatic events, which include serial homes, relocations, separation from parents, person who from a poor socioeconomic background, for person who may have especially for girls who have teenage pregnancy, and person who have sexual minorities, meaning that they have orientation which is not the mainstream orientation. Of course, children in state care. And we try to, as much as possible, trying to have promotion of activities in our clinics and our school setting, where we try to encourage youngsters how to live healthily. And some of it was mentioned before, the physical activity, getting enough sleep, and eating properly. All those things are important towards mental well-being and maintain connection with each other. And that can be delivered whether it's in the community, at schools, primary care facilities. And we're also trying to demonstrate this in public health campaigns that do your share, and the activation of wellness benches in our schools. For the adolescent, we use the CAD 6, which is a culture adolescent depression scale, and it evaluates the level of or the mood of the youngster based on 6 questions, and it says that over the last week, have you been on average or usually regarding the following? And so the mood, if they're low mood or feeling sad, you speak about worthlessness, hopelessness, letting people down and being a good person. The third one is, are they feeling tired, feeling fatigued, low energy, low motivation, have to push themselves to do what they need to do. The fourth one is, feeling life is not of much fun, not feeling good about life, not enjoying life. The fifth one is feeling worried or nervous, feeling tense. And last one is thoughts, plans, actions about hurting oneself. So for those who are average risk, then the screen is done once annually with a CAD-6, and if it is negative, then the person reaches a score of less than 6, then repeated annually. If positive, a score of 6 or more, then a full medical profile is done to ensure there's no other cause for the symptoms outside of mental cause. For example, a newly diagnosed diabetic could maybe have a score over 6. And if that is ruled out, then we refer to the specialist clinic. The high-risk person, then we want to screen 3 times yearly with the CAD-6. And if it is negative, repeat every 4 months. But if the CAD-6 is positive, they want to count a full medical profile to ensure there's no medical cause for the symptoms or any situational cause like bereavement. And if those are ruled out, then refer to the specialist clinic, which is the child and mental health clinic, for further evaluation and management. And this algorithm does summarize it. So asymptomatic, 11 to 19 years old, the CAD-6 positive, they want the full medical profile to ensure the diagnosis doesn't have any medical reason. And if there's no medical cause, they want to refer for mental assessment and treatment in the child guidance clinic. And of course, child rescreening and doing post-treatment and child guidance services will be done to monitor progress of the person in response to treatment. Of course, if it's negative, they want to rescreen once yearly for low-risk persons, and for those who are high risk, want to screen them 3 times per year or every 4 months. Moving on to adulthood. So the adulthood, which is those who are less than 60, we want to look those who are average risk, which average risk are those who are men who have no personal family history of mental disorder, have good social connection, good family support, is working and is married. The high risk one, those who have other non-communicable diseases, who are female, as mentioned earlier, females have a high risk of the depression, who have personal family history of mental disorder, who may have disabilities, who may be of sexual minority, who may have a history of negative life event or negative traumatic experience, person who have lost a close friend or relative, a person who are experiencing intimate partner violence or job loss. These are all high risk factors for depression in the adult. Again, we want to do promotion prevention activities in different settings where we might see them, whether it's in the community or in primary care facilities, at the workplace, and also exposing public health campaign, speaking about the fact that you're not alone if you become depressed. There are other persons who are depressed too, and that there's treatment available for you to recover. So we're trying to make sure we try to promote mental wellness and also trying to help persons that if they do have signs and symptoms of depression, that they should seek treatment early because it's a treatable condition where they can recover. And you might have heard about our Speak Up, Speak Now campaign, which we try to help person break the silence of not keeping the symptoms to themselves, but to share with others, whether it's a friend, family, or professional, which include persons working in primary care system. So take some time to listen. Sometimes you hear these things coming out when they're not taking the medication. So for those who are adults, and those who are average risk, we want to screen annually with PHQ-2, and PHQ-2 is negative, we want to repeat it annually. So PHQ-2, the first 2 questions were asked, during the past month, have you been bothered most of the time by feeling down, depressed, or hopeless? And the second question is, during the past month, have you been bothered most of the time by having little or no interest in doing things that you once enjoyed? So if you have a response of yes to one or both of those questions, that's considered PHQ2 positive. But if you have answered to both of them being no, then it's negative, in which case repeat it annually. So if it's positive, then go on to screen with the PHQ9, which I showed you earlier. And of course, carry out a mental status examination. If it is negative, screen annually. We screen annually. If it's positive, not only the mental status examination, we also do a medical profile examination, asking history. We have various other conditions which can contribute towards persons having depressive symptoms like hypothyroidism, endocrine conditions, even diabetes, sometimes can masquerade as being depression. It's important we ask those questions to rule out those other causes or possible causes of the symptoms. And those that can be ruled out, then we want to start treatment by a primary care physician with the straightforward cases, and then with the complex cases referred to the specialist clinic for further management. And for those who are high risk, we want to again screen and try to have early diagnosis. We want to screen twice yearly with the PHQ2. If it is negative, repeat every 6 months. But if it's positive, we want to move from PHQ2 to a PHQ9. And the PHQ9 is negative, we want to screen every 6 months for these high-risk adults. But if it's positive, we want to count again, full medical profile, check if there's any medical reason for the symptoms. And if those turn out to be negative, they want to have a primary care physician commence treatment and refer the complex cases to the specialist clinic. And complex cases will include those who are persistently suicidal, those show inadequate response to multiple treatments, and those presenting with psychotic symptoms. Because a person with depression can also have depression with psychosis, in which case you should refer them to see the mental health practitioner in the mental health specialist clinic. And the summary: person over 20 years old, adult, the PHQ2 is positive, goes to PHQ9, that is positive, then on the full medical profile, and that is negative for medical profile assessment, then you go on to treatment, primary care health practitioner, and only refer the complex one to the specialist clinic. If it is negative, the PHQ2 is negative, then you want to repeat we screen these persons every 4 to 12 months based on their risk assessment. What about the elderly population? So if they're an average risk in elderly population, those who have no history of chronic illness, those who have no personal family history of mental disorder, and those persons who are able to maintain social connection and remain physically active. Whereas those who are high risk are those who, similar to those we saw in the adult group, but also those who may have physical disorders and those who may have physical disabilities, so they have severe arthritis, so they're not so mobile anymore, and they have no children, and they lack family and social support. Those persons are high risk elderly population. Again, we do the health promotion prevention talks at different settings, especially for the elderly population. We may not only stick to the clinic and the community setting, but also senior clubs, churches, and of course, explore the public health campaign as much as possible. So we want to screen 2 to 4 times yearly with PHQ2 based on clinical assessment of risk. If PHQ2 is negative, repeat in 6 months. If it's positive, screen with PHQ9. If we screen PHQ9, it is negative, we screen in 3 to 4 months. If PHQ9 is positive, carry out the full medical profile to ensure there's no medical reason for the symptoms. And if there's no medical reason for the symptoms, then you want to begin treatment as a primary care physician, a bit of counseling and also medication. In complex cases, we refer to the specialists. Of course, if the medical profile shows that some positive, where the thyroid or the blood sugar is high, then you want to consult with the endocrinologist if you have one, or you want to commence treatment as a physician in the clinic. So the average risk patient can be screened twice yearly, but the average patient should be screened 4 times yearly. That's in the elderly population. So what about those who are pregnant and postpartum? And especially postpartum period, they're very likely can become depressed. They may have simple postpartum blues, but some actually go into postpartum depression and even postpartum psychosis. So those are average risks for these depressive signs in this period are those who are married with good family support, no issue of any chronic disease or mental illness, about good socioeconomic background, and they are gainfully employed. Whereas those who are high risk are those who have other NCDs, not working, issue of some chronic illness, using substances, previous or past history of postpartum depression, there were increased risk of having recurrent postpartum depression, unwanted pregnancy, on low socioeconomic background, relationship issues, intimate partner violence, and poor family support are all may put person at high risk for depression in this pregnancy and postpartum period. Again, we want to, in the antenatal clinic, we want to provide them with information also how to maintain mental wellness, both in terms of taking care of their physical health, maintain social connection, make sure they have enough support at home. And that's why our own situation of Jamaica, where whenever they have a baby, mother comes and is there to provide support. That's a very good thing, but I think that is somewhat dying now. I'm not sure the impact of that change in our culture. So for these, in pregnancy, on the screen and the PHQ2 every visit, which may be every 4 weeks in the initial stage. And if it is negative, on the next visit. If positive, they want to go on the screen with PHQ9. And the PHQ9 is negative, they want to screen we screen every 3 months. But if PHQ9 is positive, we want to carry the full medical profile. I have no other medical reasons found for the symptoms and for the PHQ9 to be positive. Then treatment at the primary care physician. And of course, complex case we refer to the specialist. So I mentioned some of this before, but I'll just repeat this for emphasis. So when we refer to the psychiatric services, if the patient is of a high suicidal risk or threatening to hurt himself, herself or others in terms of infanticide, which can occur in postpartum depression, if person having signs of psychosis or sign of hypomania, so they were probably once depressed and then they become very, very disinhibited, very happy, talkative, spend a lot of money, increased sexual drive, they may have hypomania, in which case those patients should be treated by the mental specialists. If having started treatment and antidepressants, especially if tried 2 antidepressants for 6 weeks at the optimal dose and person still showing signs of significant depression, they want to refer those patients for because they are failure of adequate antidepressant treatment. And persons who have complicated medical comorbidity, so they may be depressed and diabetic and have other conditions, then you may want to have specialists be a part of that management of that patient to have optimal outcome. Of course, person is mildly severe depressed, where he or she probably not taking care of self, not isolating self, not eating much, then the person may be moderately severe depressed and may need will need specialist intervention. Of course, the patient is showing signs of physical deterioration due to the fact that they're not taking the medication, they're not eating, they're looking after themselves, becoming dehydrated, then the person may need hospitalization for more intense inpatient treatment. So in conclusion, as we saw earlier in statistics in Jamaica, that depression is quite common, but it can be often missed because it can be masqueraded as probably simply not having sleeping issues or not feeling energetic enough, or not being thought as being part of a depressive episode. You don't have to diagnose whenever a high index of suspicion, and that's why it's good for us to do screening. I'm glad it's included in the profile I saw where part of admission of persons into clinics is to do screening of persons for diabetes, for depression, by asking 2 questions. And it's important because when persons are depressed, it can cause with other NCDs, and those other NCDs are to manage. And bear in mind, a person who is depressed, it can recur. Approximately half of the persons who will have a depression may have a second episode after the first episode. And can be quite costly, as I mentioned before, when left untreated, and can be cost saving if treated adequately and early enough. And it's highly treatable, and if caught early enough in a mild situation, then primary care physician can treat the person at the point of contact, and that not only improve the outcome, but also they lower the mental stigma that's attached to being seen by the mental health specialists. These are my references. Thank you for your attention. Are there any questions or comments or feedback?
Thank you, Dr. Goldburn. Thank you so very much for your presentation. At this point in time, I'll just check the question and answer to see if there are any questions for Dr. Goldburn or
Just
comments.
Just apologize that my video is not working, that's why you can't see me. I'm not trying to hide.
Okay, well, thanks for the clarity, Dr. Goldburn. But we know you wouldn't shy away or hide from us. We know that much. All right. So, any comments or questions in the Q&A? Okay. All right. So there is a in the question, there is a question that says, what treatment would you recommend for a GP to initiate at point of contact? And that's for you, Dr. Goldburn. Someone from the chat is asking.
Okay, that's a very good question. Because some patients, if they are mildly depressed, they may not need any medication. It's a matter of listening to them and hearing what are their issues and helping them to see how we are dealing with the particular situation. But if they are more than mildly depressed and they're showing some signs, and you can see with the PHQ-9 the different levels of depression, then one can start with antidepressant, and we tend to use the newer ones like sertraline and fluoxetine and citalopram. With the older person, you may want to start at a lower dose, half the dose, and increase slowly. But for the person who is like under 60 years old, you can start at the optimal dose. And as I said before, you should try that treatment for at least 6 weeks before you think that it has failed. And it's important for you to recognize and say to the clients that if you start medication now, you may not feel full improvement in a few days, like when you take pain tablets. It may take up to a week or 10 days before you start seeing significant improvement. Although you might see incremental improvement in something, like for example, a little bit more energy, a little improvement appetite, but you may not feel the mood really improve until about 7 to 10 days with most of the medication.
All right. Thank you for that, Dr. Goldburn, for answering the question. I hope that was clear. All right. Anonymous attendee, can you please put your name, please? Thank you, everyone. So they would want to say, they said, thank you, Dr. Goldburn. In primary care, many patients don't have access to specialist services due to lack. How should primary doctors manage, improve mood, but compliance of numbed emotions, libido loss, lack of orgasm in otherwise stable patient? Okay. That was a mouthful.
Yes, can you repeat that for me? Yes, can you repeat it for me, please?
I was about to ask. So they're asking, how should a primary doctor manage persons improved mood but complains of numbed emotions, libido loss, and lack of orgasm in otherwise a stable patient?
Okay, yes. So that's a common thing in Jamaica where it's thought that the medication will decrease especially men's libido and orgasm, and as a result, they prefer to not take the medication and try to struggle through the depression. However, the good news is that we do have newer medication which has less of the decreased libido and decreased orgasm side effects. So that is a positive thing. And then also is that with with counseling that can help the person to improve better. But the point is that the newer medication have less of those sexual dysfunction as a side effect.
Great. Thank you for that, Dr. Goldburn. I'm hoping that that was helpful. All right. So, right. So Dr. Goldburn would have done one of his two presentations for us. So we are going to switch gears a bit. Thank you very much again, Dr. Goldburn. And now
You're
move
welcome.
over. Don't worry, we'll be back with you shortly. And
Okay.
now head over to Dr. Hassan. But before we go over to Dr. Hassan, who would talk to us about addressing NCDs in post-disaster recovery phase, the Caribbean experience, we are going to take a little stretch break. Just if you need to stretch, with everything we encourage wellness, and so we want to stretch a bit and prepare for the next segment. So 2 minutes break, just a stretch, grab a quick water break, bathroom break, and then we'll hand over to our next presenter, Dr. Saria Hassan, and she'll be addressing the NCDs in the post-disaster recovery phase, the Caribbean experience. And then we will then look at our final presentation from Dr. Goldburn, which is the emotional first aid, psychosocial support during a disaster. All right, so 2 minutes break. Guys, we are counting down 1 minute and 6 seconds to go. So if you need to grab water, if you need to stretch, if you need to use the bathroom, please do so, and we will then transition into our next segment. And we are back. So 2 minutes would have ended, we would have taken our stretch break. All right, so now we will now hand over to our other presenter, which is Dr. Hassan, who is an associate professor at the Emory School of Medicine and Rollins School of Public Health. She's a physician trained in adult medicine and pediatrics and a public health researcher focused on improving care of people living with non-communicable diseases affected by climate-related disasters. Dr. Hassan has been working in the Caribbean region for the past 10 years. She has collaborated with the Pan American Health Organization and leads grant-funded projects to address the needs of persons with NCDs during disaster. Her expertise is in using actionable implementation science research methods that are embedded in the principles of community-based participatory research. She's earned her MD from Harvard Medical School and completed residency training in internal medicine and pediatrics at Yale. She obtained her master's in public health from the London School of Hygiene and Tropical Medicine. And at this point in time, I will now hand over to Dr. Hassan, who will be presenting to us today on addressing NCDs in the post-disaster recovery phase, the Caribbean experience. Dr. Hassan, over to you.
Thank you so much. Can I confirm that you're seeing the slides correctly?
Yes, you are. We are.
Okay, wonderful. Well, thank you so much. Thank you, Dr. Brian, for the introduction. Thank you to you and Dr. Davidson for the invitation. Before I start, I do want to acknowledge the hardship and the disruption that Hurricane Melissa has caused. Our thoughts and our prayers are with you all, and I'd also like to acknowledge your resilience, as evidenced just by your presence at this webinar here today. Thank you, and thank you for allowing me to share this space with you today. So as was mentioned, I have spent the past 10 years working on chronic disease in the setting of disasters in the Caribbean, and I'm hoping today to share a little bit of what we've learned over this period of time and provide some information that will hopefully prove helpful to you as you continue your efforts during this recovery phase. And so I have two objectives for the 20 minutes that we'll have together. The first is to really hone in on the point of why focusing on NCDs during this recovery phase is critical and how it has been shown to truly drive mortality after disasters when it's not addressed. And then I'll go to talking about some post-disaster complications that are related to NCDs with a focus on prevention and management. And so I will be drawing from my experience with hurricanes Maria, Irma, and Dorian, spanning the US territories and the Bahamas. And this really, this work really all started before Hurricane Irma and Maria. We were actually doing diabetes prevention work and had a clinical trial across many islands in the Caribbean, including Barbados and Trinidad and Tobago, when Hurricane Irma and Maria hit. And we very quickly started to hear from our friends, our colleagues, our participants in our trial about the complications related to chronic disease that were coming into the clinics. And this really started to kind of get us interested in seeing how we can prevent NCD-related morbidity and mortality. And around that time, papers started to come out looking at the causes of death. And one of them came from the CDC that clearly showed that 90% of the deaths were actually indirect hurricane-related deaths. And when they dove deeper into that data, a good proportion, over 30%, were related to chronic diseases. And I will say this is likely a huge underestimate, given this other category that you see there, but also because of what we know to be an overlap between floodwater infections and chronic disease and accidents and chronic disease. But this truly got people thinking about this intersection of NCD mortality and disasters. And if we go back even further back to other events, Hurricane Sandy in 2012, they showed that heart attacks increased by 22%. And that included not only hospitalizations, but mortality related to heart attacks. Going back even further, Hurricane Katrina. Here you see cardiovascular disease related hospitalization. The yellow bar is when Hurricane Katrina hit, and you can clearly see the spike that happened due to cardiovascular disease related hospitalizations after Hurricane Katrina. Well, what about the Caribbean? This was a seminal study that came out of Puerto Rico. If you may recall, there was a lot of controversy about the deaths around Hurricane Maria in Puerto Rico, with the official death toll being 64. And then this study came out and said, you have grossly underestimated mortality because you did not look at indirect deaths. And their calculation of deaths was actually 70 times the official estimate, at over 4,500 deaths. And most of that mortality was due to chronic disease-related issues, not being able to get your medication, equipment, transportation issues, not being able to get to a doctor, the doctors not being available, and of course, the end-stage renal disease and the dialysis needs. So again, emphasizing why we have really tried with PAHO and others to make a push on the focus of NCDs in the disaster preparedness and now in the disaster recovery phase. And the studies that have looked at this have then become numerous, documenting mortality rates due to cardiovascular disease, myocardial infarction, due to stroke, due to diabetes-related complications. And another big one is mental health and the ways in which mental health drives NCD-related complications and therefore NCD-related mortality. So with all of this information, we did do a review to help us hone in on the Caribbean. Was there something specific in the region that we needed to understand to see what was driving chronic disease-related management issues in the setting of disasters? But the same kind of things come up from what we saw in the other study from Puerto Rico. The disrupted healthcare system, communication challenges, mental health challenges, the reliance on ad hoc volunteer organizations coming in, and then access to clean water and healthy food. But once we saw this, what we really wanted to know what was the lived experience of persons in the Caribbean region who are living with chronic disease in the setting of more recent disasters. And that's where I will turn to show you some data that we have from the Bahamas and then from Puerto Rico and the US Virgin Islands. So in the Bahamas, we talked to several people across the archipelago of the Bahamas to think about, again, what was driving NCD management in the setting of these disasters. We focused on people living with chronic disease. You can see the high prevalence of hypertension and diabetes, which is very similar to what we saw in the data that was presented earlier. And a good proportion of patients with diabetes were on insulin. And the quote that I put here just is a snapshot of much of the data and the information that we were getting from that lived experience of persons. My husband passed away. They took so long to let him get in to visit the doctor. And then when he finally went to the doctor, they had to rush him to the emergency room because he had fluid in his lungs. So again, an example of why now the push truly is to focus on chronic disease management post-disaster. We looked at what people's experiences were and what were the challenges that they had. And you can see that while many just said their condition worsened, there was a fair number, at least a quarter, who said they could still, the access to medication was a huge issue, and the access to healthy food, a huge issue. In addition, when we look at what was so challenging about people taking their medication, it was inability to get a refill. Again, similar to other places, when you only have a 1-month supply of medication, if you lose that or you about to run out and you don't have a refill, that's a problem. Unable to keep medication refrigerated. We've had a lot of discussion around that in this webinar already. The role of stress and anxiety that then affects your ability to remember to take your medication, and of course, lost medication during the storm. This issue of stress and anxiety and mental health, you will see, will keep coming up. When we ask specifically around mental health problems in the setting of the disaster, 51% of patients had some form of mental health challenge after Hurricane Dorian. And this seems to be very similar to what you are seeing right now after Hurricane Melissa. So the key takeaways, there's a lot of information we could give, but in this brief time, really the main things were that NCD management is truly a challenge post-disaster, that medication access was an issue, access to healthy food was an issue, and again, this intersection of mental health and the other non-communicable diseases. Turning to Maria and Irma in Puerto Rico and the Virgin Islands, here we did do a survey of providers. These were physicians and nurses, talking first about how they handled disaster preparedness. And this has changed now, but at the time when we did the study, the majority were not talking disaster preparedness with their patients generally, unless there was an event happening. And still the focus on mental health. 71% felt that mental health after cardiovascular conditions was the leading cause of morbidity after Hurricane Maria and Irma. Our patients talked about the challenges managing their chronic disease, the focus on stress and anxiety and how much of an issue that was, that they continued to still feel not prepared after a disaster, even after what they had gone through, and again, the critical issues around mental health. I want to just give you a glimpse of some of the themes that came out of the interviews, because I think it informs a lot of the strategies we're using now to try to strengthen NCD management in disasters. So again, the unhealthy food, the mental health challenges, the NCDs not being a priority. I do think in the last 10 years, we have seen this shift. Infectious diseases continue to be a focus in the recovery phase, and appropriately so. But what we are trying to push for is for the NCD agenda to be just as much of a priority, given what we are seeing in terms of what is driving mortality after these events. Being able to self-manage your chronic disease, right? So a lot of teaching and awareness raising around self-management of chronic disease can be very helpful when you have limited access to providers. The other issue providers talked a lot about was this double burden, this realization that these same providers and their families are victims of that same disaster. And while they at the same time are managing their families, their loss of homes, their loss of loved ones, they are still presenting to serve. And they are doing that full-heartedly, but they recognize the burden that that takes on them from a mental health perspective, which is why I'm so pleased to see the focus on mental health today and the tools you're being provided with to try to address that as well. The patients echoed much of what the providers had said. Well, the only thing that came out more in the patient discussions was the continued stigma around mental health problems, which really limited people even trying to access care and support for that. With all of this information, we sat down with PAHO and many stakeholders and community members to list out some strategies that we could use, both at the personal patient level, at the health center level, and then as a system. What could we do to try to, again, strengthen our ability to address chronic diseases after disasters? And you see the list here, but I'll show it to you in this way, just because it's a little bit easier to follow. From a mental health perspective, similar to what you're doing today, we have really pushed out psychological first aid and skills for psychological recovery as tools that can be used by community health workers, by providers, by first responders, to be able to support persons in that acute setting and in the recovery phase as well of a disaster. From a social community support perspective, in many of these health centers, we now have registries of the most vulnerable. Within your group of NCDs, there are those that are even more vulnerable, those who are bedbound, those who are on insulin, as we have discussed, and those who require equipment of some sort that needs electricity. Having that registry means that you can target those people either for evacuation, for displacement to other shelters, or for checking in on them after the disaster hits. The other is medication, and you all are very familiar with the WHO PAHO NCD kits. We actually were part of the first launch of these NCD kits, which were used the first time after St. Vincent and the Grenadines, the volcanic eruption there. And I'm grateful to see that they're now also being deployed after Merluza and other events in the Caribbean region. Food, I will say, continues to be a challenge. It is hard when you can only have non-perishables, and I'll talk a little bit more about that in a minute. And lastly, awareness. Really trying to raise awareness of why you cannot wait 3, 4, 5 days to focus on your diabetes. That 5 days without your insulin is a problem. So really trying to raise that awareness, and PAHO has done an amazing job with a series of brochures they have put out to try to raise awareness for people with specific chronic diseases about what they should be doing differently in preparation, but also afterwards in this recovery phase to address NCDs. And that now becomes a nice segue to shift to talking about some specific NCD-related complications from a prevention and management lens. What I will first do is talk a little bit about the intersection of NCDs with many of the other pillars of disaster recovery. And that's around mental health, food, displacement, and infectious diseases. And then I will turn to some specific examples for specific NCDs. I think I have driven home the point enough of the importance of NCDs and mental health. The relationship is bi-directional. Mental health problems through a variety of pathways impact cardiovascular, metabolic, and respiratory conditions. But with those exacerbations, you also get exacerbations of anxiety, stress, and worsened mental health. It is important as health professionals for us to be familiar and cognizant of this relationship, to be able to make our patients aware of this relationship. And at the same time, emphasize why, despite what people are going through from a mental health perspective, it is important. The medication adherence is still a critical issue, and the adherence to the lifestyle changes and the diet that we know are so critical continue as well. NCDs and food, as you saw in a lot of the data I showed you before, the access to healthy food or the lack of access to healthy food was a big driver of NCD exacerbations, but our options are limited. From what I have been told, your actual food packages that are being delivered are actually much better than what many of the US territories received after Hurricane Irma and Maria. This is what we got in Puerto Rico, which is literally, as someone said, you either get diabetes or hypertension as a box, in a box. You see the chocolate mousse, and you see the applesauce and the Cheez-Its and the chocolate bars and the hard candy. But fortunately, your options are better. And again, the options, though, are not perfect, especially if you have hypertension. For diabetes, you can focus on the protein-based canned foods, trying to reduce that glycemic index. For hypertension, salt is a preservative. So it is harder to find low salt options, but I'm told those are also now available. And so really emphasizing to people when it's possible to focus on this. But ultimately, your patients have to eat, and they have to eat whatever is available to them. So then we just need to try to be able to adjust their medication accordingly. The other pillar is displacement, and understanding that there's a huge amount of displacement as a result of these disasters, but that displaced individuals encounter challenges that will have to be kept in mind, as those of you in the less affected parishes will be seeing many of these displaced populations. And so they, very similar to those who are remaining in the devastated parts of the west of the island, the mental health challenges continue, the lack of medical records. They have lost their employment and very often their income, and so their access to food, resources, and medication can be limited. The disruption from schools, and of course, the continued housing and food insecurity. Infectious diseases, as I've said, is always a pillar of disaster recovery. What we're trying to push is the recognition of the relationship between NCDs and infectious diseases. You all know well that any infection will worsen a chronic disease. There are some chronic diseases that make you more susceptible to infection, specifically vector-borne diseases, including malaria and chikungunya. So keeping these interrelationships in mind as you're treating either the infectious side or the NCD side is critical. Very briefly, I'll just go through some things that you just keep in mind as you're managing each of these different chronic conditions and give you some resources that you can hopefully get some more information on. Diabetes, you've just had a wonderful presentation on diabetes. I'd like to emphasize that as much as we will focus on high blood sugars and hyperglycemia in the setting of disasters, we need to also be cognizant of hypoglycemia as people continue the same dose of their medication, but very often have less access to food. And so making sure we're recognizing it and educating our patients about that as well. Hydration above all things, access to medication, and often having to shift or switch medication if we're not sure what the patient was on previously, they don't have a record of it, or for the availability of certain medications. Insulin has been discussed a lot, and the issues around safe storage of insulin, so I'm glad that discussion came up. And then infections, because this is what we saw as actually being a big driver of diabetes-related complications after a disaster, specifically foot-related infections that can really spiral in the setting of the flooding and the exposure. And so that's something also to be on the lookout for and educate our patients about. Hypertension and cardiovascular disease is really the driver of mortality. And you saw the graphs that I showed you before, that really it is within the weeks after a disaster that we see the spike in cardiovascular disease-related hospitalizations and therefore mortality. I will not go through this diagram that basically proves that there is a pathophysiology behind why we see more cardiovascular disease after these disasters, but it's a variety of causes that we've already talked about: the stress, the salt intake, the medication adherence. And I'm thankful that you have wonderful guidelines for the management of hypertension and just being cognizant that in post-disaster setting, much of this will increase. Asthma, you have beautiful asthma action plans as part of your asthma guidelines. The one thing people forget is the inhaler safety. If inhalers are wet or have been soaked in flooded water, they should not be used, even if you can still pump them, because they will not be safe in terms of the material that comes out. Cognizant of tobacco smoke exposure that can increase in the post-disaster phase, and of course the mold. But before I get to mold, I will just say that the asthma handout from PAHO also talks a lot about post-disaster asthma management that can be helpful to all of you as a nice way or a nice tool to give your patients. Mold is a huge issue after floods, and safe cleaning of molds, really cautioning your patients with respiratory conditions when they're trying to undertake cleanup after a flood. Cancer, of course, is very difficult. As much as we try to ensure continuation of cancer therapy, recognizing that immunosuppression makes them at very high risk for any type of infection, including airborne diseases, and of course, the relationship between mental health and your ability to manage your cancer. End-stage renal disease and your dialysis-dependent patients are another always challenge. We do have guidelines for renal emergency meals. So these are patients who we know will need to skip their dialysis because of lack of access. There are some recommendations you can give them for their diet to try to reduce complications when they're going to be going 5 days without dialysis. So in summary, a large proportion of mortality after hurricanes is due to poorly managed chronic disease. This is multifactorial, the main ones including medication access, diet, and mental health. Truly trying to integrate an NCD into parallel efforts of infectious disease, providing adequate nutrition, and managing displacement. And that is health professionals remaining vigilant of NCD-related and NCD-specific complications during this recovery phase, but really a call for the continued strategic, intentional, and cohesive approach to NCD management during this disaster recovery phase to save lives. And so with that, I'll end and have my contact information here for questions.
Thank you so very much for that very informative and presentation, Dr. Hassan. Really, really appreciate you taking the time. All right. So before we jump into questions and in the question and answer segment, I'll just segue into our final presentation from Dr. Goulburn, and then we'll just have a Q&A segment. And then guys can just post your questions to the individual presenters. All right. So Dr. Goulburn would be presenting our final presentation for this evening on emotional first aid, the psychosocial support during a disaster. And at this point in time, I will hand over to Dr. Kevin Goulburn. Dr. Goulburn, over to you.
So I can find my slide here. So I want to thank Dr. Hassan before me, who did an excellent presentation underscoring that mental health needs are very common and very significant component in the post-disaster period and can affect the outcome and prognosis of persons' conditions, and hence we cannot overlook it. So this evening I will just present in brief on psychological first aid as a means of providing support after disaster like Melissa, which I can tell you from going in the field, it's a very important thing because most persons are wanting to just hear from persons to provide that support for them. And apart from getting the physical relief, they also want to have the emotional relief or emotional support. So we'll look at what is PFA or psychological first aid. Is it only for healthcare professionals? When should we use PFA? Where does it fit in the whole scheme of mental health and psychosocial support? Is it critical or not critical for it? And then we look at the essential components of PFA and the scope of PFA, what it is and what it is not. So PFA or psychological first aid is a supportive approach which should observe human rights and a practical response to those who may be adversely affected by a disaster and will need support. I've noted this approach is not restricted to healthcare workers, and even laypersons can be trained in using this approach. And what it does is help to identify or bring to one's attention needs, especially of certain groups of persons who may become particularly distressed during and after disaster. And include children who may find it hard to understand what's happening, the elderly who, because of their state, they may not be able to move and to respond and to what is necessary to keep themselves safe. Persons with disabilities, those persons homeless. Of course, we can't forget our frontline workers and our first responders. There are also persons who definitely may show signs that they need support during this time. So this is showing that when we have any form of disaster or humanitarian crisis, persons respond differently to it. For example, I'll never forget during COVID-19, a colleague of mine, he was just over himself. He was just energized, whereas most of us were distressed about COVID-19, extra long work hours and so on. And similarly with disasters like Melissa. So bear in mind, a person may respond differently. So some person may show signs of little or no distress. Some person may have mental distress. Some person may actually have mental health problems. They become heartbroken. They may become demoralized. Maybe end up grieving because of loss of loved one, loss of physical health, loss of livelihood. As we have seen, a lot of persons would have lost their crops, their animals, their houses, and in some persons may actually have mental disorders. And it's expected in a time like this that as you go up the severity of the mental response, that you have less persons at the top, as demonstrated by the smaller peak of the pyramid. So where does PFA falls into the picture? So we have 4 levels of psychosocial response. You have level 1, which is at the bottom. You have level 2, level 3, and level 4. So level 4 is at the top. And the pyramid shows that as you go towards the top, we're expecting less persons to need level 4 intervention. But level 1 is very crucial. So level 1 is where we want to attend to persons' basic needs for water, for shelter, for food, for clothing. And it's addressed to the general population. So the target group is general population. And ensure these basic needs are met and that person's human rights are respected in providing these services, and ensure these persons have access to reliable source of information. So as a result, it involves persons who are belong to NGOs, first responders, person in civil society, person in regional health authorities, and also journalists who will be the ones who will be disseminating information in one way or the other. There's also at this level that the psychological first aid is important. Because at this level, this is where we actually try to reach general population, not only with care packages, not only with trying to assess the level of damage to their houses and their property, but also trying to find out how are they feeling, how are they doing. And as one lady said on the news, on the radio, is that even though she got her care package, she was not happy. Why she was not happy? Because nobody came and asked her how she was doing. Nobody came to ask her how she was doing, how she was faring. So she felt very disappointed that even though she got a care package, her emotional well-being was not addressed and got to become more distressed. And yet when soldiers came by and had much more compassionate conversation with her, she felt so much better. So we can't overemphasize the importance of this psychological first aid. Again, this is the next demonstration to show Psychological first aid is at the bottom of the pyramid here, and what is important to provide basic services for persons, ensure they are taken care of, and that we actually provide emotional support. But what are the components of this psychological first aid? The first component is when persons who are trained in this skill set or an approach, they are trained to, first of all, when you go to the setting where the person is, whether it's in a community, in a shelter, that you look, you observe. Are there signs of distress seen in the person who are before you? They are showing signs of fear, of being fearful. Are they showing signs of being confused, not even knowing their own name or the exact location where they are? Even though they brought to the shelter, they don't want to know where they are because they're so confused. They may be restless. They may be the ones who are quiet, who sit by themselves alone, not talking. And sometimes we can easily overlook this person because they're not creating a mayhem, not creating a stir. But if you observe carefully, you see a person who's in a little corner by him or herself, not talking, or someone who's sobbing uncontrollable, person who's just sitting there and staring, or a person who have no expression on their face, almost as if they are numb. And then we must forget those persons who may be seen using excessive amount of drugs and alcohol. And an interacting person might actually see persons expressing feeling guilty about surviving or guilty about not saving others. So the first component of the PFA training is to train in approach to make sure you look and observe from verbal and nonverbal cues how the person is feeling. Next thing is to make sure you listen. And in listening, you want to ask the person, is there anything I can do to help you in your situation? How can I help you? And by listening, you may get to find out what it is that concerns them most. Is the car they lost? Is it the house that's damaged badly? Or is it the relatives who they're not sure where they are? They haven't heard from them, they haven't seen them, they're wondering where they are. You also listen, you want to listen to see where their strengths are. And you also want to listen to see, are they expressing feelings of despair and loss? And by that, you can gauge to see how are they doing emotionally. Now, having looked and listened, then one can arrive at a need situation. What are they in need of? And by assessing this need, you want to link them. For example, link to available resources for basic needs, which may be for temporary shelter, maybe for more food or water, maybe for some dry clothing because all the clothes were wet in the disaster. But tarpaulin to cover the house, or bedding because the bed was so soaked. So as a PFA helper, you want to make sure you are armed with the available information where those resources can be had. You also want to assess from your interaction, are they in need of health services for injuries that they sustained in the hurricane? Or they may need help with a medical condition, they're out of their insulin, out of the medication because they forget to bring it to the shelter, for example. Also, you want to listen to see if they have concerns which show signs of distress, or they may have a mental condition before, which has exacerbated. And you know, resources that they can access, which if there is signal, they can call the mental health and suicide prevention helpline at 888-639-5433. Or in some instances, it's difficult to make calls, but they can text. In which case, they can text the human chat line by texting support to 876 838-4897. And also you, as a PFA helper, you want to know or get in contact with the local mental health team if you ascertain that this person is expressing emotions far above what is expected in this situation and may need mental health team intervention. In the disasters, as I said before, the emergency situation where they may want to know what happened to their loved ones, or they may want to answer what will happen in this Melissa, what will happen to their property that they have left when they've gone to the shelter. And as a PFA helper, you want to help them to build cognitive resources. For example, you want to call them to AdPem where they can get resources like tarpaulin, where they can relieve supplies from, financial assistance to get them back on their feet, assistance to restart their agricultural occupation. So the PFA helper, you want to link them to see how we can help them to deal with their particular situation. By linking them, that can help them to feel more supportive, that someone has listened to them, so now observe what they're going through and help them to provide answers. Because you know, the more you have a problem and you don't have answers, is the more you feel more overwhelmed. So if you provide some answers for them, then it helps them to weather the storm in a better way, in a better frame of mind. So PFA is not something that only professionals do. And a professional counseling or therapy, so you don't spend time trying to counsel the person and trying to get detailed discussion of the event and what has caused the stress. It's not for that purpose. You're not asking someone to analyze what has happened to them, why they feel so distressed. It's not for that interaction. You're not pressing somebody to find out what really happened in the house. How were you going through that experience? How did you lose your roof? No, it's not for that type of interaction. And not to pressure a person to share their feelings and reactions to an event. As you often see on our audiovisual media, where a person are asking how are they feeling or what is their feeling about a particular event. Those things don't help them to bring emotional relief, help them to rehash the problem and make them feel more hopeless and more helpless. And PFA is supposed to be helping the person to manage the stress that's caused by Melissa. So what is PF? PF is where you comforting the person who's in distress and helping them feel safe and calm as much as possible. It's about assessing what are their needs, what are their concerns, not what you think they need and what they should be concerned about, but you're trying to find what do they need, what is the issue, what are their concerns, and trying as best as possible to address those needs and concerns. Protect them from any further harm. So you don't want to do things that will make them feel worse. I said, simply by rehashing what happened to them in the experience, when they lost a roof, the wall fell down, those are rehashing the experience and will only cause further emotional trauma. Providing emotional support for them, empathy, where you just be there for them. Sometimes even a hug is all they need. Tap on the shoulder is also all they need. Of course, PFA will definitely involve you making sure the basic needs are met. Food, water, blanket. Somewhere to stay even for a short time, to catch for a short time. And of course, important is to link them to reliable information, services, and social support. So in providing PFA approach, we want to avoid persons to feel that the way they are feeling, they shouldn't feel that way. By saying things like, oh, you only lost a door. Why you seem to be so worried about it? Or saying to them, comparing them with someone and say, oh, compared to your neighbor, you haven't lost much. Why are you so bothered about it? You should be thankful. Or on the other hand, overpromise and say you can, whatever issue they have, you can solve it and everything will be fine. Or trying to say to them, no, there's no need for you to cry. Stop crying and be happy you survived. Trying to avoid allowing persons to express their feelings and own their feelings, but you're trying to just be there for them to bring them solace, to bring them comfort, and some sense of hope. So the only do that PFA is for you to keep calm and with a reasonable pitch voice, so the person feel like you're not shouting at them, you're not seeming to be angry at them, you're not commanding them, but you're there to support them. Of course, you should show active listening. Shouldn't be distracted by your cell phone or others around you talking to you. So mother possibly trying to have a very secluded area you can talk to them in privacy if possible. In short, you are interested in what they're saying by maintaining good eye contact, not being easily distracted by what's happening around you. And remind them that you are there to help them wherever is possible. So PFA is not a soft skill. I want to put it to you, PFA is a core skill that not only the healthcare worker should have, but all persons should have. Because it's useful in the home, in the community, for the policeman who's there dealing with persons who need to evacuate, for the fire brigade man, for everybody. It's important that we all, as much as possible, be exposed to the PFA approach, because it helps and it's a basic skill that can help persons to manage the storm in a better way and less likely to need the further intervention because they become in mental distress and have mental problems. And as emphasized before, the average lay person can be trained to use the PFA approach, which provides emotional support. And remember, is a level 1 approach in the mental health and psychosocial support. And PFA, we encourage persons not to try to do more than they can do, but encourage them to refer those persons who seem not to be sufficiently comforted by their approach so they can get further intervention, maybe from the uh, a, a problem management plus person or a counselor, psychologist can refer them to those persons, or even to speak to a helpline counselor. And one last point is that you can actually do a virtual PFA course, which is self-paced, where you can do it. It's estimated to take about 15 hours to complete. And one way to do it to make sure it is not just something on paper, we can actually do it as a group where you say you do like 3 modules, and then as a group you discuss what you learn from the module and even try to do role playing to see how you can actually utilize the skills learned from the PFA course. So when you have the real life situation, you'll be better able to utilize it. And that's PFA in a nutshell, which is a very important part of what we're doing now. Actually, some of my team members have gone down to the Western region to provide PFA support to both healthcare workers and patients and their families. And that's the end of my presentation. Any questions or comments or feedback?
Thank you very much, Dr. Goldburn. Thank you so much. Want to say thank you to all the presenters for this afternoon's presentation. I mean, it was really insightful and we really appreciated you taking the time out to come and present. So at this point in time, while we're wrapping up, we'll now just offer some time for any questions or answers to we had some questions in the chat. Dr. Goldburn, the PHQ doesn't include screening for mania, and we miss bipolar sometimes. That was one of the comments that was noted in the chat.
Yes, and that is quite true. And and as I mentioned that sometimes patients may present with mania as a part of their presentation. But in most instances, when a person is manic, it is somewhat easier to detect because of their talkativeness and their disinhibited behavior, very friendly behavior, and they're willing to spend a lot of money and so on. So sometimes it's a little bit much more obvious for a person to see those, as opposed to depression, where a person may just seem withdrawn, seem to have a bad day, and person may somewhat not see it so easily because they're not causing a stir, they're not causing a disturbance in the situation, and that way sometimes it may be missed more than the manic symptoms. But you're right, Some person may have bipolar condition where they have depressive episode followed by a manic episode or the other way around.
And there was another chat that says that also many doctors doesn't realize that depression mimicking effects of medications. Are there any recommendations for that?
And that's why when we mention about the PHQ-9 becoming positive, that one trying to go through a detailed history about medication, about any other signs and symptoms which may be attributed to other conditions, and even do tests to find out if there may be other reason why the person is presenting where they're presenting. And in the event that you have a medication which may cause depressive symptoms, may want to think about using a substitute and see if that makes a difference in the patient's presentation. So some medication will make patients feel a bit weak and drowsy and less interactive. And for knows about that, they want to think about changing medication to another medication which doesn't make them so drowsy and decreasing energy and see if that makes a difference.
Thank you for that, Dr. Goldburn. Then there was what happens when depression precedes the mania episode and antidepressants are given.
Okay, that's a very insightful question because yes, and that's why it's also caution person when give antidepressant that you don't just give antidepressant and don't review them. But it's important that one also monitor to see the move them in depressed and not become very happy in a short order, more energetic, not sleeping, then them essentially from depression to mania. And that's why a good history will also help you to give an idea if there have been mood swings in the past, one, if there's a history of mood swings in the family, in which case you can look out for bipolar disorder. And then we have to be so careful then when treating those patients to treat them very carefully in terms of prescribing for them and see them in short order. Because sometimes we do use antidepressant in patients with bipolar disorder, but only for a short time to improve their mood. When the mood is improved, we discontinue antidepressant and continue with a mood stabilizer, like valproic acid or lamictal.
Thank you. Thank you for that, Dr. Goldburn. Hopefully that answered your question, Dr. Rodriguez. At this point in time, we just want to say any further questions or comments in the question and answer for any of our presenters before we wrap up and then head to our post-test. Great. Okay, so if there's no further question or comment noted in the question and answer, I just want to say thank you, a big thank you to all of our presenters. Thank you so very much, Dr. Phillips, Dr. Goldburn, Dr. Hassan, for taking the time out, for coming today and sharing and imparting, some of the knowledge that you would have had, some of them with us. So that, today when we leave here, we can say, yes, we would have learned something, and you would have imparted something, to leave with us to take away from this webinar. We really want to say thank you very much again for all the presentation. They were very insightful, and we definitely would have learned some things today. Thank you to the participants for attending. We really appreciate you taking the time out of your busy schedule to sit with us for 2 hours just to go through, these presentations and just to discuss these topics, for for this NCD round webinar series. Thank you to Dr. Davidson, our director for the NCD unit, for giving our opening remarks, and thank you to the rest of the team for also, assisting and to ensure that this webinar was a success. So at this point in time, we now will just place the QR code up, as well as drop the links in the chat for the post-test. Please remember to complete the post-test so that you can receive your CMEs at the end of this process. And also after completing the post-test, there's also be an evaluation just to, let us know how the webinar was and, how we can improve and maybe other things that we can look at to bring to you, to go through as we continue to, go through this time. So thank you, everyone. Thank you very much, everyone. And please remember, guys, complete your post-test and evaluation. And we continue to, work together and the collaboration, and we continue to move forward, one together as a collaborative. Have a wonderful afternoon.
Bigger break. Which one already? In farmer coming back to town, right? What? It's your bag. No, just make sure I'm alright. I'm not it. Yeah, we're wrong. Just make sure. Tinder,
All right, guys. So just a reminder, the post test as well as the evaluation, the links were dropped in the chat. So please feel free to just complete the post test for your CMEs and your evaluation so we can get your feedback so we know how today was and just ideas of what for further presentations or webinars to improve. All right, thank you very much and have a wonderful afternoon.
Hi, Miss Vassal, you can go ahead. Oh, let me open your mic so you can speak. Can go ahead, Miss Vassal. Miss Vassal, you may go ahead. You have a raised hand. Or you can type in the Q&A if you prefer, Mr. Julie K. Vassal. You have a raised hand. We want to be able to assist you. You can go ahead.
Okay, if you're hearing me now?
Yes, I am.
Okay, I was saying I'm trying to submit my post-test response, but
Mhm.
it's not allowing me to. It's
Okay.
saying that I have an updated draft or saved option. I'm constantly clicking submit and it won't submit.
Okay, let me see if we can
So
address
could I
that.
submit?
Hmm.
But my internet, I'm in Westmoreland, the connectivity is very, very poor. So
Okay.
I'm constantly dropping off, coming back on. So I don't know if it's because of my bandwidth.
Okay. Is anyone else having that issue as well? If not, Miss Vassal, what you could do is just send your email address in the Q&A section if you don't mind, and we'll note it, and we could send it to you in your email so you could do it when you have a little bit more email in a bit this afternoon. Just note that for you.
Okay, no problem.
If it's not too much trouble for you to.
Oh no, I mean, I want my certificate, so that's
Yeah.
no trouble at all. All right, I'm typing
Okay.
my email now. Thank you.
Okay, you're welcome. Okay, we have your email, so we're just going to send the link for the post test. What about the evaluation? Are you getting to the evaluation, Miss Vassal?
First thing that I saw just post-test. I made an error. The pre-test was done via vasaljodike@gmail.com. So that's where the pre-test was done, but I would want it to be sent to my personal email, jodike@yahoo.com. But I didn't see an evaluation.
Okay, I'll put it. It's in the chat, but I'll place it again in case it timed out a bit. Whoops. In case it timed out a bit. It went from when last it went up. So I'm posting it again in the chat now.
Okay, thank you. I'll see if that will submit.
Hi, Miss Shamlon. How are you? Great. Sabin. See, on the hair. And remember. Yes, yes, please. I see a missed hand. Michelle. The hand just went back down. I hope you're able to come back on. Michelle was just here. I noted a raised hand and then I don't see you anymore. I've missed that person.